So like I said before, we're going to give people just a minute to sign on, get settled, and then we'll begin. Okay. So I'm going to go ahead and start. Thank you for joining the PeerTAC workshop, Strengthening Peer Support Documentation Practices, presented by Yvette Kelly and Maria Fuentes at the inaugural Supervision Summit. I am Angelique Rodriguez, and I'll be the moderator for this session. So I'm going to go over some housekeeping rules. For technical support during the session, please text Stephen Nowotniak. Stephen, feel free to put your number, email in the chat, or people could chat to me directly. Again, my name is Angelique. Your microphones will be muted and cameras off to eliminate any background noise and distractions, so please make sure you're muted. We encourage you to use the chat box to introduce yourself and ask questions. And choose everyone in the chat for your comments to be visible to all attendees. And choose host and panelists to ask questions for the moderator or presenters. Just a reminder, this session will be recorded, and a link to the recording, presentation slides, or any handouts or resources will be posted on the PeerTAC website. I will also be putting all the links in the chat. If you lose connection or accidentally leave the Zoom room, choose the link next to the title of this workshop in your program to rejoin. And if you need any help, reach out. If you're seeking CE credit, you cannot use a phone link. 10 minutes are reserved at the end of the session to ask questions. You will receive instructions by email for completing the workshop evaluation and earning CE credits for your participation from the Alliance. With that, PeerTAC would like to thank Yvette Kelly and Maria Fuentes and everybody who worked on this to make this happen. To learn more about them, feel free to see their bios and visit the Supervision Summit and Leadership Forum page on the PeerTAC website. And finally, please join me in welcoming Yvette and Maria. Thank you.
Yeah. Thank you. Thank you, Angelique. And hello, everyone. And thank you for joining our presentation today. I'm just going to offer just a brief introduction to myself, and then I'm going to turn it over to my co-presenter for today to do the same. So I am Yvette Kelly. I am one of the co-directors of the Peer Support Services Technical Assistance Center, or what we call PeerTAC. I am a licensed mental health counselor by training and spent many hours in my career working with children and families. One of my primary roles was overseeing a children's behavioral health clinic. And in that role, I had to gain a clear understanding of documentation requirements to obtain timely payments from both Medicaid and third-party payers. And is that experience that I'm going to be sharing with you today as we walk through what it is that we need to do to support effective documentation practices. And with that, I'm going to quickly turn it over to Maria just to provide a brief introduction before we move forward.
Thank you, Yvette. Good morning, everybody. My name is Maria Fuentes. I am a family peer training specialist at PeerTAC. I work with NYU McSilver since December. I worked for almost 6 years in a New York City Department of Education pilot program providing mental health services and peer support services to families in the public school system. That's me. I'll turn it over to Yvette.
Thank you, Maria. All right. And so here is what we hope to accomplish during our time together today. So this presentation, we are going to review the importance of accurate and timely documentation and mental health service provision. We're going to describe how the assessment, the service, or the treatment plan and progress note fit together. We're going to detail what information is necessary for Medicaid billable progress notes. And lastly, we are going to talk through some strategies for supervisors to support effective documentation practices with their supervisees. And so with that, here are the topics that Maria and myself will be covering during today's presentation. And again, you can see them here. These are all in support of meeting the objectives that I just discussed. All right. So we're going to begin today's presentation by really orienting everyone to some general principles as it relates to documentation, generally in the field of behavioral health. And so let me just say a couple things. So there's a couple terms I'm going to use synonymous, and I'll go back and forth with them. And so behavioral health, mental health, really what we're going to be talking today about is really just the fundamentals of meeting requirements in this space. And so I want to be just clear about that. And so none of the principles that I'm going to be talking about today are new, but it really does set the stage for why we want to talk about documentation as an essential component of care. All right. And so as helping professionals, part of the role and responsibilities in providing quality services includes properly documenting in the record, right? So that is one of the things that as a professional, helping professional is an expectation. And because a record really must, I would say, and I'm going to say must, be ready for inspection at any time, it really is important that providers develop good documentation habits early. And so that when the record is requested, there is not missing information from the record. And so we're going to talk through some of those expectations. And so there are several expectations around documentation that are really integral into the role as a helping professional. And this includes really maintaining high quality documentation related to the services the agency is contracted to and subsequently provides. And so here's just a couple keynotes to understand. That while the agency is responsible for the upkeep of the record, it is expected that the individual and the family have an active role in contributing to its contents. Okay, so the agency is the holder of the record, but the individual and the family is the one who is really kind of contributing to the contents. And so from that perspective, it is really the client's record. The cost of documenting services provided generally is included in administrative costs, right? And so when you are hired to provide a service, the expectation is that high quality documentation will be a product of the service provision. All right. And so knowing what and how to document is really the key to being efficient in this task. And so we're going to talk a little bit about again, some of the fundamentals and how supervisors can support developing effective documentation practices among their staff, right? And this is, just from my experience in the field, this is an area that supervisors as well as other workers have asked about, like what exactly do we need to be doing when it comes to documentation? And so we don't have a lot of time today, we do have some time to talk through some of the logistics, and we'll also leave you with some resources around documentation. So in this discussion, it's really imperative to really understand what is meant by the record. And so, here's a brief description of the record, like what it is, who does it, when it's done, and where it's done. For the sake of time, I'm not going to walk through all of these. I'm going to assume that everyone on this call is at least familiar with behavioral health record documentation, but I will leave this slide in for you to reference at a later date. And so we'll just talk through, but again, for level setting, I think it's important for all of us to just understand when I say the record, what I'm referring to. So one of the things that really needs to be continually stressed is how important documentation is to our work. As helping professionals, we really need to learn to value documentation as a representation of the therapeutic process it represents, and not just something that is seen as an unrelated mundane task. And it is within a supervisor's role to really relay and reinforce the importance to supervisees around keeping, accurate and timely documentation. And so when we value this process, we understand that really documentation serves valuable purposes to our work. And so some of those purposes, it really is a vehicle by which providers can communicate. It acts as a repository for where the individuals and the family's needs, services, and progress is recorded. It also provides the basis for reimbursement. And overall, here's the one thing that I like to say, it really substantiates all of the hard work that is done by providers, right? And so that's important because I know in this field, we are working hard to really support individuals and families in their recovery. And we want to get credit for it, right? We want to get credit for it. So there's a lot of other reasons, again, that I just mentioned. But again, we also want to kind of just say, hey, here's why we're doing this work, right? Here are some of the outcomes that we're seeing from this work from. And how do we know that? It is through the documentation practices. And so that's a very important aspect when it comes to that. And so we talk through why are we doing it? Why are there so many rules and regulations around documentation? And so I think ultimately, when we boil all of this down, is really to think through this is the individual's record and really substantiates the care that they're getting. And when providers really fail to document appropriately, we're actually depriving individuals and families of the ability to access necessary information when needed. I have had the experience of individuals requesting records from an episode of care during childhood in order to receive a specific entitlement for which they should have been eligible for, but unfortunately the record was incomplete. That was a very unfortunate circumstance, and one really that I would say no provider likes to be responsible for, right? And so we have to just remember that this is the individual's records and it serves many purposes. And so that really just give credence to why we want to make sure we're doing this accurately. When providers fail to document, it also leaves the organization vulnerable to accusations around the lack of quality service provision. And so let me just say also that the lack of timely documentation really is one of the first red flags to poor service provision. And because most of us have heard the saying, if you didn't document it, it didn't happen. And so just to follow that logic through, and if it didn't happen, then agencies can't be reimbursed appropriately for the service. So it's a rather simple argument when we think about that. But it is unfortunate if the providers are doing all of the great work with individuals and families, and they've taken their time to really work hard and diligently with families. And then at the end of the day, agencies can't be reimbursed for that services. The providers don't get credit for that, all because they haven't documented it appropriately. And so again, just wanting to think that through. And so again, we come back to the importance of documentation. But also just to say that becoming proficient in documenting is really a skill set that needs to be taught and refined. As supervisors, let's not make the assumptions that folks who come to your supervisors who come to you when they're onboarding, that they know what is expected around documentation practices for your organization. This is something that should be talked about. This is something that supervisors should be meeting with their supervisees and talking through the expectations around documentation and how your organization documents. And it should really be a part of the onboarding practices that you have for new staff around documentation requirements. And again, I say that because sometimes we make assumptions that this individual came to us and they have been working through with a different organization, and so they know how to document appropriately, and that is not necessarily the case. So as supervisors, we really need to make sure that we're supporting all of our staff and being able to meet the documentation requirements set forth through our agency. And so for all of your supervisors who will be supporting individuals and completing documentation tasks, here is where you need to start. We're going to walk through some just basic fundamentals around documentation. And again, the fundamentals can be used across the whole behavioral health service continuum, right? So what I'm gonna talk through today is things that you can do in all different service environments. We're going to talk through the fundamental requirements. So when we talk about documentation, especially in a Medicaid billable world, but in the healthcare setting in general, there's just a couple concepts that are fundamental to documentation that supervisors need to be aware, supervisors and their supervisees need to be aware of. And I know that these terms have been thrown around before. So I like to really relay these terms. I like to boil them down to just very simple language. Because I think the more we don't do that, the more complex it gets, the more like people want to like stay away from it. And so one of the first fundamental principles related to documentation is the concept of medical necessity. And so very, in short, kind of the concepts that this is a concept that states that the healthcare services rendered must be necessary to treat qualified conditions that inhibit an individual's functioning. All right, that's just in short, that's what that means. And so this is a standard that is utilized in healthcare in general, right? Not just behavioral healthcare, but behavioral healthcare is a segment of healthcare. So that is really the standard. And it's the standard to authorize and pay providers for the services delivered. Okay, so that's just the concept of medical necessity. Just means that there is a concern or an issue that is impairing someone's quality of life or their functioning, and that they need some services to help mitigate that. All right. And that's kind of the basis for being reimbursed for the service. And so to that end, if the documentation does not detail medical necessity, then the services won't be authorized because basically they'll say you have not identified a need. There's no impairment, there's no challenges, there's no issues, and therefore they're not authorized and therefore not billable. So just a reminder that when documenting, in part, you're documenting to meet this standard, right? Medical necessity, that there is an identified need for this particular service. And that is all what medical necessity means. And so that does have to come through.
It's going to be like this. It's going to like pile on,
And so so you have to make sure that you're understanding that you are documenting to this standard. The second is this concept of the golden thread. And what the golden thread references is really the need for all of the documentation in the record. So the assessment, the service plan, the progress notes to be interrelated or connected, right? It is a concept that weaves together all of the critical information and provides a comprehensive view of the individual. And so the reader of the record should see the logical connection between each piece of documentation, beginning with assessment and then really culminating with billing and reporting. And so this is how the golden thread concepts gets articulated in the record. And so you'll hear in the behavioral health space, you'll definitely hear about the golden thread. And as a supervisor, this is one of the things that you want to attend to as you are working with your supervisees and really helping them develop good documentation practices. And so just to flesh this concept out a little more, this is really just an illustration of it, and after this will be just an example. But so when individuals seek out services, right, they come in for an assessment and meet with individuals to really kind of flesh through what their needs are. After that, there's a service plan, and in some of your organizations, you call it a treatment plan, but really that plan is just to structure the services to accomplish meeting those identified needs, right, by identifying goals and objectives. And then the other piece of that is really just the progress notes that really substantiates the work that is done toward meeting the goals and and objectives identified in the plan. And so if we were to kind of look at this in terms of an example, and again, this is just to illustrate the golden thread. Here's just a quick example. So Amina has been assessed. She's struggling with managing her fears and worries. She's been diagnosed with general anxiety disorder. Let me say that does not mean that a peer is diagnosing her, but we're looking at the record in totality. So someone has assessed that issue. The service plan then is for Amina to find ways to improve her ability to kind of cope and manage her anxiety. And so that's kind of what we're working on in terms of goals. And then the progress notes are going to say, like, basically give kind of the strategies for what you're working on and her response to that. So Amina continues to struggle with her anxiety, but she's made some progress in connecting with supports when feeling overwhelmed. And so that is kind of the link that kind of demonstrates a little bit of the golden thread from assessment to service planning to progress notes. And so when we talk about assessment, when an individual seeks out behavioral health service, the first thing that a provider must do is simply identify what the needs are. And this is done by meeting with the individual and their family and reviewing their concerns and challenges, right? So at times, it also includes reaching out to others who may have some useful and relevant information about the family and their needs. And so why is this important? And it's important for two main reasons. And again, I'm just going to boil these down to very succinct reasons, right? Here's the reason for that. It's to help the individual or family seeking services. So they have come with a need. They want that need addressed. So we're assessing what that is. And to establish medical necessity or need for the services. Again, that is the bottom line of what we're doing when we're talking through assessments. And this is important because it really is the foundation for goal setting and service planning, right? Individual comes with us, identifies that they're struggling or having a challenge. They want assistance and kind of remedy some quality of life issue, let's just say that. And they've come to us, and one of our goals is to figure out how to support them in that. And so after we gather that information from the assessment, we then figure out what it is that we're going to do that can be a support of the family, right? So the next step is really to articulate and document what services are going to be rendered to help the individual or family meet their goals, right? And so we develop a service plan. Again, I'm going to use service plan synonymous with a treatment plan, depending on your agency, how you identify that. But it really includes the goals, right? So these broad overarching statements of what the family wants to achieve. Then the objectives are really the specifics of who, what, when, how often, and why. And then the interventions, which are the methods, the resources, and supports provided to the individual or family to really assist them in meeting their goal areas. And so essentially that's what we're doing when we're service planning. And all of this is stuff that we need to connect in the documentation practice itself. And then again, once the assessment is completed, the goals identified in the service plan developed, then there needs to be evidence that these services, couple of things, that these services were rendered, that the services connect back to the need, and the individual is benefiting from the service. And that really is the purpose of progress notes. And so I'm going to say all of that, and let me mention that this is not a static process, right? I'm presenting it as a little bit of a static process, but there's a couple points that I want to mention here. This is actually a very dynamic process, right? So providers will need to allow space to update, change, and modify needs and goals based on the progress that is being made by the family. And so the key here is just making sure that that gets captured in the documentation process. And so as supervisors, when you're meeting with your supervisees to talk through, what are peers doing with individuals and families and how they're supporting the family to meet goals that they've identified, you will have discussions about, they originally perhaps wanted to work on this, but they're finding out that that really isn't what they want to work on. They want to work on something else, or something significant came up and we now need to make a mid-course correction. Absolutely, you do that. You just make sure that that gets translated in documentation so that you're able to maintain the golden thread. Remember, I'm going to go back to a couple key concepts, which is that the whole purpose is that whoever picks up the record is able to see what the family is working on, where they are in their services, and kind of what needs to happen next. It is shameful if for instance, if another worker left and did not leave that information intact in the record, that people have to start from scratch. And that's not fair to the individual, and that's not fair to the family. And so again, just want to kind of go back and bring it back. That's why documentation is so important. So here are some of the common golden thread issues that as a supervisor, you can be looking out for, right? Because maintaining the golden thread requires a constant focus on meeting the needs of individuals and documenting in a way that both establishes the need for services and provides information that supports decisions and interventions and really overall service provision. All right. And so as a supervisor, you should be able to spot the telltale signs of misalignment in documentation. And again, we're talking about, let me just be clear, we're talking about translating the work that peer support workers are doing into the record. And so here are some of the signs. Progress notes don't link back to the goals and objectives in the service plan, right? In order for it to be billable, it does have to link back. That progress notes address a variety of issues, none that have been identified as a need in the assessment or in this or the service plan. So if a new need emerges, which will happen, you just got to make sure to put that in the service plan so that when you go to work on whatever issues or concerns that is, that has been linked appropriately. The specifics of interventions used in sessions are not described clearly or not within the scope of the role. If you went to the keynote speaker, Shireen talked about things, what is in scope within the peer role. That is really what should be clear in the documentation, right? And so folks should know based on reading the note in terms of what were some of the things the peer support individual did with the individual that they're servicing to really help them meet their goals. Goals and objectives are not individualized or not connected to assessment findings. Again, we just talked through how all that should be interconnected. And that the service goals or the objectives and the interventions are not updated when new issues emerge. Again, this is a very dynamic process. I always say that you can update these things all along the way. Although some organizations or agencies may have timelines, minimal timelines for when a service plan or treatment plan should be updated. It is a minimal timeline. So if for example, if the timeline is, you must update the service plan, the treatment plan every 3 months, but month 1, there's something that requires a change, you should go in and update it on month 1. And so just wanted to be clear about that and share that. Oops, I'm gonna ask maybe, I'm just having, oh, there we go. Okay, sorry, having some moving the slides issue. And so I'm gonna stop here for a minute before I move quickly through just some charting essentials. I see there were some questions coming in, so maybe we'll just take a couple questions. I do want to be mindful of the time. There's a lot of information here, but Angelique, is there any questions that folks are chatting in? I'll try to look as well?
Yes, I took down about 3 questions, so I'll ask the first one. Somebody asked, what if the clients are in denial about their mental health issues and refuse to share their diagnosis? And also in a similar vein, people are asking about what are documenting symptoms, barriers, what is being impacted, and how is it being addressed? So yeah, I guess addressing the struggles that come with documentation sometimes.
Yeah, so I think those are all good questions. And so I think when you're meeting with individuals and families and if they're not really accepting or not not ready to hear what the diagnosis is, I think that could be a challenge. But really, I think when they're getting services, I think there's a process where we talk with individuals around what does it mean to be in services at this particular agency? What does it mean that, if you seek out services based on how, and then this is just like an education piece, right? So based on, here's how our services work. It means that you'll meet with someone who will do an assessment to really work with you to identify your needs. After that, we'll have a discussion about what was found through that, right? And you can voice your opinion about whether you agree or disagree with that. I mean, I think you just have to have an open conversation with that. We are not going to force feed anyone about, if they're not open or able to accept a diagnosis, but we really want to provide some psychoeducation around why it is that diagnosis has been identified and what that means in terms of service provision. So I think that is done gently. Let's understand that people are, sometimes people are coming to services with long histories of service providers who have not been, how can I say this? Who have not met them with dignity and respect, and we have to understand that. I think when you form relationships with the individuals whom you're serving and you're taking the time to get to know who they are, what their concerns are, and that you are reflecting that accurately in the record, that there is space to address that as time goes on. And Angelique, you had what was your last question? I'm sorry.
So yeah, I asked that one, and then I asked what about documenting symptoms, barriers, what is being impacted, and how is it being addressed?
Yeah, so I mean, part of and part of this conversation is around Medicaid billable kind of notes. And so again, we'll go back to the medical necessity need. So in order for services to get reimbursed in this model, there has to be some understanding that there's a need, a qualified need, so that services can be delivered. So you have to address that in the documentation. But you need to do that in a way that is very respectful of individuals, and you need to keep individuals in the loop and on board. I think if you give the impression that you're doing things secretly or behind their back or not asking them for their feedback, like it is their record. And that was kind of my whole kind of opening. It is their record, and at any time individuals that you're serving can ask for their record. And so we want to be mindful of that. We want to be respectful in our communication, not just in the communication and the translation of that into the record, but really in the process of working with individuals. All right, I'm gonna move along. We'll leave some time at the end for questions. So if more come up, we'll have an opportunity to address them there. But I just want to kind of make sure we get through this content quickly, so that you get to hear kind of the meat of the presentation, which Maria will be sharing with us. So, so here, when we talk about quality documentation, this diagram really highlights the characteristics necessary for effective documentation. Here's the key here. Quality services and quality documentation is a complete package. You can't have one without the other, right? And I think that's important to know. So a quality service provided without quality documentation is not a quality service. And so again, just highlighting the need for us to be mindful. And so here's some just charting essentials. about documentation. One of the things that you'll hear me repeat about documentation is that it should reflect factual and accurate information. It should be free of speculation and judgment. And so what does that look like, right? Here's just a really brief example. So when I arrived to the home, Naomi stated that she and her husband were involved in an altercation that resulted in her having a black eye, right? Very factual. Arrived to the home, that's what she stated. Here's the difference when it's not. When I arrived to the home, Naomi had a black eye because her husband punched her, right? Do we know that? We don't know that. The only reason that we know it in the first example is because we articulated that she stated. This is her view, she stated. And so we have to be mindful about that. I know it's very nuancy, but in terms of translating into the record, it's very important. We want to ensure that our records are really reflective of our service provision. So we need a clear and concise record of services provided. Obviously, you know, how records are generally managed, or they are from chronological record of past to present. If you're including other people's information in your notes, and sometimes you will, because like diagnosing is not within your scope, but you want to kind of draw some conclusion around the diagnosis and what the symptoms are and kind of how you're going to be intervening. You might say, you know, per this report, you know, individual has been diagnosed with general anxiety disorder, blah, blah, blah. So you want to make sure that if you're not doing it, and that's not within your scope, so that's the point that you want to make sure that you pay attention to here. You just want to identify the resource in which you've got that. And of course, all notes require signatures and credentials. Another key point here is we want to make sure that the record is reflective of relevant information in appropriate detail, right? Only provide information that is directly relevant to the delivery of services for the intended client outcomes. We have some other resources that you'll find at the end of this document. We call it the Documentation Done Right resource, which is, you can access it on our website. There's a number of workbooks that will walk through some of these concepts that I'm giving in more detail. I'm kind of giving you the high level overview. So if you want to learn more about that, you can link to them at the end of this presentation. But I think overall, what we want to make sure that we do is we keep information about the family and about the services relevant to the services provided. We don't need a whole history about what's happening in our families and, you know, individuals' lives that we're serving that is not related to service provision. It's actually pretty intrusive. And so we want to make sure that we do that. And then, of course, we want to make sure the information is legible and retrievable. And I think what we want to say is that information should be really easily interpreted over time. In behavioral health, we use a lot of acronyms. So we need to make sure that if someone were to pick up that record 10 years from now, they would understand what was written. In the example I shared earlier, where I spoke about the individual requesting records from an episode of care during childhood, in order to receive an entitlement. That request was from an individual who received care 6 years prior to the request. So we need to make sure that the information can withstand the test of time. So when you're writing, if you are writing in acronyms that really pretty much are not universal, I would encourage you not to do that. And then I think also just being mindful that we want to make sure that we have proper sentence structures and grammar such that it makes sense to the reader. But I also want to say on the other side too, you don't have to be a great writer to write good documentation notes. You could write it in shorthand, but we do understand that it is the record could be subpoenaed by court. And so we want to make sure that the professionalism is coming across in the note. And so again, we can talk more about just making sure that that we're only relaying the necessary information, but the spelling, I mean, most of us have spelling checks, and the sentence structure is accurate. Oops, sorry about that. I'm having some challenges with the slide today, so my apologies. And lastly, before I pass it over to Maria, just we need to get better about being timely in terms of documenting the work that we're doing. And again, the key to this task, if you really, I'm going to go back to that first slide. The key to being efficient in this is really knowing what and how to document. Oftentimes people are documenting way too much, spending too much time on including information that is not necessarily needed for the note. And so once you get those keys down in terms of understanding what and how to document, you can write a pretty efficient note that covers all of the requirements for billing purposes. And I'm going to shoot for the stars here in 5 to 10 minutes. And so that's a far cry from having to spend 20 or 30 minutes on documentation for one session. And so that's going to be important here. And so I just want, when you think about the documentation, here's some things to think about as supervisors, right? And so we want to make sure that, if we want to really take, I think, a pulse on our own supervision practices and oversight, and really ask ourselves, how does our supervision practice measure up to being able to understand, how accurate is the record if the required documentation is not completed as close to the event as possible? How available is the record if the record is not current and up to date? And how reflective is the record if the required documentation is not completed with the participants and input? And so again, as a supervisor, if you want to figure out how you answer these questions, and reflect on the practices at your agency. And if you can't really say, if any one of these are kind of not in line, then thinking about how you work to remedy that. And with that, I'm going to pass it over to Maria.
All right. Well, hello, everybody, again. So now we're going to talk about peer support documentation specifically, and what does this look like? So let's start with this. Maintaining the golden thread, as Yvette was saying before. This is also highly important in peer support documentation, as it is required by Medicaid. So this is a little bit of a play on words, right? Golden thread. What is or are the goals or the services that are being provided? Making sure that it connects the goals to the services covered by your agency, making sure also that it is person-centered. Now, keep in mind that if there is ever an audit, that you can make it easy for them to find those connections. That is super important. Next, please. Thank you. Can I have the next slide, please?
Sorry.
It's
There we go.
Thank you. So the core competencies for peer workers reflect certain foundational principles identified by members of the mental health, consumer, and substance use disorder recovery communities. What are these? One, it is recovery oriented. So peers partner with people that they serve to support them with hope and building on strengths, walking along with people, recognizing there are multiple pathways to recovery. It is also person-centered, as I mentioned before. The peer services are always directed by the person receiving the services. It is a personalized service with the needs of the persons, or the person or the persons being served as they identify, right? That's very important to note. And I'm going to say that a lot throughout my presentation. It is voluntary. Peer workers work as partners or consultants to those they serve. They do not dictate services to the person. Services are always a choice from the person or as a request. It is also relationship focused. Relationship is a foundation to peer recovery support services. It is important to highlight that peer work is respectful, trusting, empathetic, collaborative, and mutual. It is also trauma-informed. Peer work utilizes a strength-based framework which emphasizes physical, psychological, and emotional safety for the person to rebuild a sense of control and empowerment. Next, please. Now, talking about supporting peer support, service delivery and documentation, peer documentation should demonstrate a clear focus on recovery and resilience. Important activities that support core principles of peer support, such as empowerment, hope, voice and choice, person, family center, culturally and linguistically responsive, and community-based. Making sure the support that is based on shared lived experience, because that is what peer work is, right? The evident collaboration with other service providers, highlighting safety planning and care coordination tasks. Those are the connections that we need. Identification and connection with formal and informal supports as needed and or as requested by the person or persons. Next. Using human experience language is an important skill and a challenging one. Peers can often fall into what I call, I made this up, the code switch trap. Since we have been through many systems and learned the language to communicate and advocate for ourselves and our loved ones, sometimes we can talk the same way as providers do and write that same way, but that's not helpful. So, that's something that we can definitely talk about and be supportive for supervisors to be supportive with peers, right? Using the person's words, their terms, their preferred name, pronouns, remaining respectful of their culture and their customs. Use strength-based person-first language. For example, Gabby shared with me that she felt comfortable to begin advocating for her second child, Jaden. Gabby is empowered to help make changes in her and her son's life. Next, please. Now let's talk about progress notes for peers. The information that must go on a note specifically can be done following these steps, which are important and necessary, making writing a note a bit easier too. We need demographic information. We can answer this W questions, right? The who, where, when. We can answer those questions to give us a little bit of a starting point. Goals and objectives. What specific services were provided to address the person's need and or concerns? Interventions provided. What strategies were used to support the person or the family, and identified goals? Plan of action. What are the next steps as the person has described their desire to be? What will happen next, right? We need to note that as well. Lastly, when will you meet again? Is there a set weekly or biweekly meeting? Is this in person? Is this virtual? How are you guys connecting? It's important to also know. Next, please. Now, this is a sample workflow of peer documentation. This is simply an example, not necessarily, right? Sometimes it's hard to write notes, and I know that's something I struggle with at the beginning of being a peer. And I'm going to talk a little bit more about that, but here's an example, right? So person's name, who is the service for? Let's say it's Doris. Service provided. You're providing peer services, you're providing coaching one-on-one because this person is sad. The Doris is sad. What is it that you're doing with this provider? With this person? Encouraging her to recognize learning skills for coping, journaling, such as journaling, walking, and yoga. When do you do this? You do this on a weekly session with the advocate or the specialist. And why is it that you're doing this? Well, Doris self-reported that she has been dealing with sadness and low motivation. So what would that peer note look like? Using person-centered language, I would say, Doris met with Maria in a weekly session. I encourage Doris to recognize and use some of her learned skills dealing with her sadness and low motivation. Some skills Doris mentioned she had are journaling, walking, and yoga. Doris shared that information during the last weekly meeting with me. Next week's meeting will continue supporting and empowering Doris to be able to manage her symptoms in healthy ways to feel better. I know that for me, it was a little bit of a challenge when I had to learn to put writer. And I know that it sounds better when you're writing a note, right? Doris met with writer because that's you're writing on the third person, and that is something that clinicians do. And that's the code switch part, right? Those are things that I learned because I was working with clinicians. Person-centered, I think it will emphasize that you're writing as if this was a narrative, right? You're writing a little bit of a story without too much. So this will be an example of it. Next, please. Thank you. Very important information to add on a note and for peers to get used to using. Don't forget who is the participant, if there were any family members present, and any providers present. What are the interventions? Any activities? What exactly took place, right? What is it that you did? Where's the location of this? Where did it happen? Did it happen in the office, at the person's home, at the park, at the Dunkin' Donuts, whatever it is, however your services are provided? When did this happen? The duration of the session or the meeting that you had with this person. And why did this happen? The reasons behind providing the services, the intervention, how does it relate this to the goals, and what were the benefits of providing the services to the person? Now, this is the content of peer support providers' progress notes, and it has consistently linking back to the peer support provider's purpose and role. Connects to the individual's stated goals, such as as per the person's request, of course, define life goals and objectives, define desired changes that capture strategic sharing of lived experience. It also details steps in navigating various systems to assist this person and the family in having access to those supports. Next, please. It reflects support in decision-making, problem-solving, advocacy, skill building, development, and community connections. It identifies strengths, capabilities, interests, preferences, needs, hopes, dreams, and priorities. This is what peers do. This is what peers base their work on, right? That support, that one-on-one support. Use quotes whenever possible, whenever in documentation, which will clearly reflect what the person said. Address willingness and motivation to invest in recovery. Do not forget to include those that care about them. Recovery happens in a social context. Remember, they're part of a community. They're part of a family. Remember to include people that they have, if there is anybody, right? Chart each person's recovery journal and provide an opportunity to reflect on success, accomplishment, and lessons learned. Remember, medical necessity. Oh, thank you. Medical necessity. Person-centered and family-driven care. Trauma-informed care. Person-centered care and family-driven approaches put the participant and their family, in case of a minor, in the driver's seat as a whole person and not just a diagnosed, as an expert in their life and what they need, and as a decision maker in charge of their care progress. This means our approach as providers should be collaborative and strength-based, and it applies to documentation as well. Next. So what does a peer support note looks like versus a clinical note? They're both very important. I really want to emphasize that. There are differences to it, but they're both very important. Also, note that support services are not meant to be standalone services. Peer support notes use language of ordinary human experience. It focuses on recovery and resilience, includes the person's strength. It uses the person's goals for recovery. It is all about that person. Clinical notes, on the other hand, uses clinical language such as diagnosis, symptoms, medications. It focuses on symptoms management. It identifies challenges to be addressed. It explores root causes of current challenges. And it provides recommendations for services. So they're different, right? But they're both important. And I would like to mention that because of the way clinical notes are written sometimes, peers sometimes feel not so comfortable reading them because of the way they're written, right? So we have to also be mindful, as Yvette mentioned before, make sure it's person-centered. Make sure that you're being mindful of the words that you're putting in there, right? Because when you read somebody's record, when you read somebody else's notes, you are getting a story of this person in your mind already. How do you want to see this person? How do you see this person already? And personally, that was one of the reasons I didn't like to read prior to having a client reading those notes. I wanted to make my own idea of who I was servicing, right? And then getting to know that person. That being said, I'm gonna give you guys the scenario. I'm gonna read it to you as it says here, okay? So, meet Drew. Drew is an addict that began using drugs and alcohol around 12 years old. Drew was manipulative and a real party animal. The addict hit rock bottom and even cut the wrist. The cutter was out of control and placed in rehab at age 13. Drew's mother was unfit, and so the addict emancipated themselves at age 14 from her and abused the system. Whew, I had trouble reading that one. It triggered me a little bit. So what impression do you have of Drew from reading this note? Can you tell me, can you put it on the chat for me? Like, how do you see this person if I'm reading it to you? You could throw words in there. So if this was a chart that you were reading and this is how I'm putting Drew out there. Dysfunctional, out of control, yeah. Trouble, yes. Disoriented, dysfunctional, yeah. Interesting. A lot of dysfunctional. Trouble, out of control. Yeah, that's what you hear, right? Absolutely. Thank you so much for that. Now I'm gonna introduce you to Barry. There's another one I'm gonna read you. You can tell me, what do you think? Barry is a person that has a substance use disorder. Barry is a resourceful and talented actor that began their career at 11 months old. Their mother took them to many parties, and Barry was exposed to substance at a young age. After a couple of years, Barry couldn't successfully cope with their substance use disorder and needed treatment, which they received. Barry's mother was experiencing barriers to successful parenting. Barry decided to emancipate themselves at age 14, as that decision seemed to be self-advocating for their best choice for recovery. Now, what impression do you have of Barry from reading this note? Right? Bright, intelligent, yes. Absolutely, right? He sounds like a person. He sounds like somebody that you probably know. This could be yourself, right? It's really interesting to note that Barry and Drew are the same person. right? You're talking about the same person in two completely different contexts. So listen to how important it is to be mindful of the words that we use. Yes, bright, intelligent, capable. And this is something that can definitely talk about during supervision that will be able to support that. Lastly, thank you, Yvette. um, these are some common progress notes errors, right? These are some things that we can pinpoint. They're not set from bad to terrible, but these are errors. These are mistakes that we make sometimes when we're working with skill building that can be worked on. Long notes, it's not necessary, but sometimes it's tricky to get used to, especially when you're when you're starting off. You want to put everything in there because you feel like everything is necessary. You feel like everything is relevant. How can a supervisor support this? You talk about it, right? So what are the highlights? What are the little things? Little by little, you get used to it. Little by little, it shortens the narrative, right? You need that support. You need to work that collaboratively with the peer to be able to do that. Given a play-by-play, again, it's hard to do because sometimes we don't know what's important. So what is relevant? Hard to tell, but supervision can be used to work these things out. And you can use everything that I gave you before to be able to do that. Over-explaining what the person or the family share. It's really tricky, right? You're over saying the same thing over and over and over because you feel like either you need to say it or you need to emphasize it. And if it needs to be highlighted that badly, talk about how can it be highlighted once and why is it relevant to the services and to what the person needs. Peers' feelings getting in the way of the note. Remember, trauma-informed supervision can be very supportive when it comes to this. Peers need that trauma-informed safe space to be able to make those notes better. That's very important. Another error is not connecting goals and services. Don't know what that is, but everything else is there. Well, let's talk about that, right? Like, how can we make sure that it does, even if it's by prompting? And lastly, using judgmental language. Again, mindfulness, being very mindful. If we're thinking of how is it that we're writing this note? If you're writing that note about a loved one, what would it look like? If you're reading that note about yourself, how would you feel about it? It's very important to know. Thank you so much.
Yeah, and thank you, Maria. Thank you for that. Very helpful. I'm going to talk quickly just through some strengthening documentation practices as a supervisor. Let me just say, if you are a supervisor, the one thing that I would encourage you all to do is to you yourself become fully acclimated in terms of what the requirements are for notes, because it's hard for you to teach it if you yourself are not comfortable in that process. So a couple like gems I want to just leave you with. Again, I said this at the beginning of the presentation. When onboarding staff, really dedicate time to reviewing the documentation requirements. Don't make assumptions that they know what to, they should be documenting. So please have that conversation with them, support them in developing the skills. Listen, they don't need to come day one having all of these skills. You can help refine that for them, but you need to make sure that they've been properly trained. And make sure you have some time, dedicated time, really sacred time that you have for your supervisees so that you guys can work together on kind of onboarding and all of the things that they need to be aware of in terms of doing the role. Remain consistent in your review and review for the following, not that the peers will be making any diagnoses, but they may be operating from the point that someone else on the treatment team made that diagnosis, and they're supporting the work to help that individual and family mitigate some of the challenges and concerns that they've come to understand that. So I want to be clear about that. That's why it's important for all of us to be on the same team and all of us have the same information, right? We shouldn't be segmenting out information because that person's a peer and this person's a clinician. Like, you're a team, work together in that, right? Yeah, remember that when we talk about medical necessity, we're talking about a clear reason for the initiation of services, right? How is it impacting the individual and family? What are the goals that they want to work on? And what are the interventions as from a treatment team that we're going to do to really support the family? So very, very important. When we are reviewing supervisees' documentation, take brief notes about any questions that come up as you read them. I would encourage, as when people are new, for you to really start the process by reading their documentation and helping them refine what information needs to be included and what doesn't need to be included. When you're chatting with them, are you noticing any patterns that are emerging over time, such as, perhaps they are including statements. And this is really, again, general for really any new practitioner to the field, not just peer support providers, but for supervisors. Here are some of the things that you could be looking out for. Also, when they're doing a good job and, writing documentation, make sure you highlight what they're doing well so that they continue to do that and they get positive feedback. Utilize supervision time to write a note together, right? So some people need to learn by doing and by modeling. And so this allows you to really summarize and highlight what are the important points, like what do you keep in, what do you take out, what's important for this particular note. So helping them do that in supervision is a great opportunity for that space. Allow the supervisees to make the needed correction. So there's a lot of times that as a supervisor, sometimes for time saving sakes, you may see an issue with a note and you make the correction. I'm going to encourage you not to do that, right? Because the only way people learn is by doing it. So send it back, give some guidance, talk about it in supervision, allow the supervisee to make the correction so that they know what's expected of them the next time. And here's like one of the biggest skills: stagger the skills you'd like them to achieve, right? Don't work on everything all at once. And again, people will not necessarily come to the table with all of these skills, right? And you don't want to bombard them. You want them to learn. So create a learning plan that really staggers the skills that you want them achieved. Don't work on everything all at once. Very similar to like how you would work with your families, right? And the individuals you serve. And then once they get a handle on one skill, one area, then you move them to the next. And that really can support their learning. If there are other people who are really good at documentation, perhaps you connect them to like a peer who can assist them with that and just help them show them the ropes. You want to create an action plan for catching up on notes. If you notice folks are falling behind, don't just let them continuously fall behind. Talk with them about it. What's getting in the way of you getting this done timely? Can we come up with a plan and really hold them accountable to that plan? And then again, role model by keeping your own records of supervision with supervisees. That's one of the best ways to role model. We should, as supervisors, you should be documenting and have a supervision record of the time that you're spending with your supervisee. So you want to document those discussions, their tasks, their professional development goals, their achievements, and you want to detail any areas of concern or areas for growth, and you want to kind of consistently be working on that in supervision. So that those are some important pieces if we're talking about how to work to strengthen documentation practices. And then just some things to leave you with, and I'm going to open it up for questions. I do want to leave a few minutes. That it is the individual or family's record. They have a right to inspect the record at any time. So it's important to be clear about the facts and be accurate to avoid embarrassment for the individual and the family, but for yourself as well, for the agency employer. We want to make sure that we are replicating what our families needs accurately. Progress notes should read like a story of the individual's time in your program, detailing the steps of your interventions and the individuals and the family's response. And then there's always a chance, again, that your record could be subpoenaed by a court or some other entity. And therefore, you want to make sure, again, you're giving the best representation of the individual or the family and that it's factual. And we want to make sure that it's concise and up to date. And so those are just a couple of the things that we want to leave you with. And we do have some time for some questions. So maybe I'm going to ask Angelique to kind of help us out here and just kind of point me in the right direction in terms of some questions that have come through.
Okay, so the first question that I have, it says, what about assessment tools such as ACEs, aggression, lethality scale, etc.? Should peers be using these tools?
So I think that I think if the question is around should peers be utilizing tools, so there's a number of tools that are screening tools that the general kind of broad community can use. And so you would need to look and see if those are tools that, first of all, if you would need to be, whatever training they have available for that tool, you would need to do. So I guess all in all, what I'm saying is there's no exclusion from using a screening tool if it is open to the broad community to screen for a number of different issues, but that would need to be agency determined and tool determined, right? So you would need to make sure that whatever training the tool requires that you have received and that you're able to utilize that screening tool.
Okay, great. Next question I have. Not every need that arises relates directly back to the current service plan. What are some key ways to document accurately while also maintaining the golden thread?
Yeah, so that's a great question. So if I would say that if a new need arises for an individual and you said the need is not always related to the service plan. So I think you have to make a decision about, is that within your scope of addressing? Or is that something that you're going to refer to a different provider? So and maybe this is like, let's just say currently there's no active issue around housing, but a housing issue comes up while you're working with that particular family. That does actually impact the care that you're giving someone. You probably want to know, recently this individual's housing has become unstable, referred individual to a different service provider to address that. So you would do that in a progress note. You wouldn't necessarily update a treatment plan or a service plan around that, unless it was really, again, having a significant impact. However, if there is an issue, so just say when you first started working with the individual, we were working on anxiety, or just say that, and now some new issue has presented itself, and it is within the scope of the agency to address that issue, then you want to track back to that treatment plan, get that treatment plan updated, and then move that concern forward through the progress notes.
Okay. Perfect. Any recommendations for consequences related to habits of not completing documentation on time?
Any consequences? I'm not sure I quite understand the answer. I think, except for just in general, as we'll go back to the opening slides, the consequences is always that it's not advantageous to the family. That's like the bottom line here. There's other consequences, which means your organization won't get paid and reimbursed for the services adequately, even though a person may have done and delivered the service, which is to me the worst, right? Because they're doing the work, but they're not able to get reimbursed for it. But ultimately, it's the record. It needs to be accurate and reflective of the care provided. And again, as I mentioned, sometimes individuals and families want access to the records for other services they may be eligible for. And if the documentation is incomplete, you're really doing that individual or that family a disservice.
I know Bill has his hand up.
Absolutely. So Bill, if you want to unmute, and
Oh,
I think we're having a little bit trouble with your audio.
yeah, I can't hear them.
Yeah.
Would you like to put it on the chat?
Yeah, type it in the chat. I know he mentioned he put in quotations, I think, with what you said, and hold them accountable. What are some ways that this could be done?
Yeah, can you hear me now?
Oh, yes, we can. Yeah, that's better.
Listen, I appreciate everything you've done today. That's great. One of the things that is often said in webinars like this is that, this has to be done for all the reasons that you said, and you have to, and you have to be ready to hold them accountable, meaning the peers that are doing the documentation. What I don't hear is like, what are some of the ways that you can hold them accountable?
Yeah.
And that can be a really tough challenge because, what they're going through and all the rest of that stuff, but there is that documentation, there is that professionalism, what can we do before we say, this is not working out?
Yeah, good. I think that's a great question. So I think consistent supervision, first of all, is important. I think you make sure that you're paying attention to that in supervision. So if it's a task and they have not been able to meet the mark on that you're making sure that you're assessing with them, right? What is it that they need to be successful? And it's parallel to working with families, individuals and families. What is it that you need? How can I be supportive? What are the plans that we're going to put in place? Okay, let's try this plan. Let's see if it works. If, we'll reevaluate it. And then if it doesn't, okay, let's try this plan. And then at some point, unfortunately, depending on your organization or agency, you have to identify what the kind of next steps are from a disciplinary process. But I would tell you that is probably very far down the road, because you want to make sure, you want to really assess what's getting in the way, and make sure that there's not like any, if they need any modifications, that's addressed, that you've provided all of the training, and you've done that. And that you've worked with them to develop a plan. And so, Bill, I hope that answered your question, but those are just some of the ways to hold them accountable. And in part, that means holding yourself accountable as a supervisor.
Yeah, I think most of the people here who are supervisors are doing that. We understand what our roles are and all the rest of that stuff. The part where you said at some point, that's the part that I'm talking about. That's the part that tears us apart. And I think you have addressed it in a way. It says, what is your policy and procedure when it comes to that?
Yeah.
That's the point where I say, we tried all of this, we tried all of that, still not hitting the mark. And that's the part that I was interested in, what some people might have ideas on.
Yeah.
Thank you.
Yeah. And I know it's 12 o'clock. We're a little past time, so we're going to close out. I love all the questions. But just to say that, understanding, I think when that documentation or documenting the services is part of the job responsibilities, right? And can't have quality service provision without documentation. So I think it's important that when you're onboarding folks, that they kind of really come to that understanding, and that's reinforced constantly. And so I'm happy to stay. Angelique, I know I see two other hands raised. I'm happy to stay on a little longer and just entertain those questions, but I know folks need to jump off. So maybe quickly, you just see what the questions are.
Trying to look, the chat is going off right now.
Okay.
Let me see. I don't see a lot of questions. I just see a lot of
Okay.
comments.
Perfect. Well, thank you. Thank you all for joining us. We're happy to have you. Hope that you enjoy the rest of the presentations for the summit this afternoon. And again, we have a couple resources that they'll be available on our PeerTAC website. We also have a little handout that Angelique just put in the chat for you that really we worked on, that's around languaging and how to pay attention to your language and use strength-based language in your documentation. So we hope that you find that helpful. And again, thank you all. We appreciate your time. Enjoy the rest of the conference.
Thank you so much.